Katie Schubert. I'm president and CEO of the Society for Women's Health Research. And I think we have a really great panel and hopefully a great conversation following that to come. But for those of you who may not know, the Society is a national thought leader and nonprofit dedicated to advancing women's health. And our mission is to do that by, through our science programs, policy, and education while promoting research on sex differences. And I can think of no area that actually sex differences becomes more clear than in cognitive function, cognitive health, brain health, and Alzheimer's disease. And we'll hear a little bit more about that later as well. So today, we're here to talk about Alzheimer's disease. And I think for me, as we think about this growing public health crisis, I, having been in women's health for a very long time, was surprised to learn that Alzheimer's actually disproportionately impacts women. So it's something that I think for us, we take very seriously. I know all of the folks here today do as well. But beyond sort of the medical facts of Alzheimer's, dementia affecting memory, thinking, and behavior, there's a stark reality that this disease is not just widespread, it is deeply personal. And as I mentioned, it disproportionately impacts women. So of the nearly 6 million Americans aged 65 and older living with Alzheimer's disease, 2/3 are women. It's the leading cause of death for women in this age group, and a woman in her 60s is twice as likely to develop Alzheimer's disease as she is to develop breast cancer. So things that we know about women's health, we think of breast cancer often, we may not think of Alzheimer's quite as often. So we feel that this is a sobering truth that calls for urgent attention. The economic burden is also staggering. We're hearing a lot these days about the economic burden or the impact of investing in women's health and what that means for our economy and society. In 2025, Alzheimer's-related care costs are projected to reach $412 billion. And by 2050, that number is expected to surpass $1 trillion, which those are not small numbers, especially even up here. Those are still large numbers for us. With an estimated 13 million Americans expected to be living with Alzheimer's disease by then, early detection and improved diagnostics will be essential to improve outcomes and to alleviate demands on families, caregivers, also most of whom are women, and our healthcare system broadly. So we're excited today to have a great panel. We're joined by Dr. Julie Dumas from the University of Vermont, Diane of the Milken Institute, Brigid Reynolds from Georgetown University, and Jennifer Pollack from the Alzheimer's Association. So thank you all for joining us. We're going to have a great conversation. What we'll do is we'll have opening remarks from each panelist, and then we'll come back together for some Q&A. So think of questions as well, because we want to hear from you too. And before we do that, I want to give a very special thank you to our sponsors, Eli Lilly and Roche. We would not be able to conduct these programs without their support. And I'd also like to thank Senator Hyde-Smith's office for helping us arrange, as some of you know, it has been very difficult to get space up here. So we really appreciate their assistance and support as well. I note that we maintain editorial control over all of our materials and our events. And with that, I am going to invite Dr. Dumas to kick us off.
Okay, let's see. Thank you very much, Katie. Let me move a little closer for the introduction. Thank you for having me here today. I'm going to talk about Alzheimer's disease and sex disparities. I know we have a lot of experts in the room, but I just want to get everyone on the same page. There are some early signs of Alzheimer's that are likely to get somebody a diagnosis of Alzheimer's disease. They include things like memory loss, disorientation or confusion, difficulty with everyday tasks, difficulties with challenges with problem solving and decision making, personality and mood changes, and declines in judgment and decision making. And who does it affect? It affects mostly people age 65 and older. The risk increases with age, family history, and genetics, and those risk factors are not modifiable. So for example, we can't do anything about how old we are. And interesting for us here today is that 2 out of 3 people with Alzheimer's disease are women. So what's the cause of that? One explanation is that women live longer than men, and that certainly does impact the numbers that we heard about a few minutes ago. Another is that there's something different about the biology of a woman that's likely to impact her risk for Alzheimer's disease. My work focuses on hormone changes in a woman's life. We're going to talk about menopause in a few minutes. Another time period is pregnancy. And we don't know exactly how those things are causing Alzheimer's, but we think they're involved. So here's some illustrations of this increased risk for women compared to men. The sex differences in the development of Alzheimer's. The women are in purple, the men are in orange. You can see there's the risk of 20% different or 10% difference at age 65 is still there at age 85. Then if a woman gets Alzheimer's disease, she's likely to have a worse trajectory. So the numbers going up in the second, the one on the right indicate worse performance. The women are in green and the men are in purple. And you can see that as the disease goes on, women have more impaired cognition over time. And so what's the cause of Alzheimer's disease? It's caused by some abnormal buildup of proteins in the brain called beta-amyloid, amyloid plaques, and tau tangles in and around brain cells. And the picture in the middle is a cartoon of a brain cell, and you can see some amyloid plaques around it, which impair the functioning of the brain cell. And the picture on the right is an illustration of plaques of the tau tangles with the amyloid plaques. And they lead to the shrinkage of the brain, the sort of that brain half on the right side is shrunken, there's extra space. That's something you don't want in your brain. You want it to be nice and fat there in your skull. And this impacts functioning. So far, there's no cure for Alzheimer's disease. All the medications we have impact the symptom development. They slow the symptom development, but there is not yet a cure. So what can we do about it? Can we do anything about it? We already mentioned the non-modifiable risk factors, and those things are going to be there. But there are a few modifiable risk factors we can target, and this doesn't take away risk completely, it just reduces risk. One is maintaining good cardiovascular health, so we want to maintain good blood pressure and good cholesterol, even from an early age, as soon as those things start to creep up. We want to be non-sedentary, we want to exercise, get out there and move. And exercise is one of those cures for all that ails us. It's not a cure for Alzheimer's, but it will reduce risk here too. We want to have a good diet, healthy dietary pattern, so good fats, healthy oil, fruits and vegetables, healthy nuts, things like the Mediterranean pattern. Folks who follow that dietary pattern have reduced risk of Alzheimer's compared to a more Western style diet. We want to maintain social interactions. This is sort of the opposite of loneliness, being socially engaged as we continue to age, as well as continuing to use our brain. And then, of course, not smoking reduces risk. So we want to be able to detect Alzheimer's disease early. We want to detect it before it really takes hold, before we see those clinical symptoms. And in order to do that, before people have actual memory impairment, we need something called, we need to find biological markers. So in Alzheimer's disease, we might have imaging biomarkers and fluid biomarkers. The imaging biomarkers are things like MRI or a PET scan. PET scan, we can actually look at the proteins of these amyloid proteins and tau proteins. The picture on the right of that brain has that hot red at the front of the brain. That's amyloid showing up on that PET scan. That person probably has cognitive impairment and Alzheimer's disease, compared to the brain on the left that does not have the hot red at the front. However, imaging is really expensive. It takes a lot of technology. It's hard to access. So fluid biomarkers would be a little bit easier to access. We can look at cerebrospinal fluid, the proteins there, although that takes a spinal tap or a lumbar puncture. And blood tests are really the thing that would be most helpful here. Recently, there's the Persivity AD test, which is commercially available. And the reason there aren't more commercially available blood tests is that it's technically difficult. So the researchers are working on developing the blood test, but we're not quite there for all of them yet. We can also look at genetic biomarkers. There's a gene called ApoE, and there's a bunch of different variants that increase risk or decrease risk, and we can tell us about our risk profile. So this is an illustration of the life course. On the bottom we have birth to all the way to death, and the 0 is the development of cognitive decline. So a few years after we have cognitive impairment, we might get a diagnosis of Alzheimer's disease. And once we're symptomatic, it's really too late to stop it. We might be able to slow down that decline, but there's no stopping it as of right now. So what we want to do is perhaps modify that trajectory, modify when it starts or how steep the decline is. And my work focuses on menopause, where we might think we can modify or maybe prevent it. And the real the thing that would be great is if we could prevent it from happening at all. And that people are starting to look in utero even. We don't know exactly what we're tweaking or what we're looking for, but we need research and clinical care at all of these time points, at the prevention, the modifying, and the symptomatic. So let me just talk briefly about menopause and our work. So menopause is a really interesting time in a woman's life. In the past 100 years, the life expectancy of women has increased to about age 81, but the age of menopause has not changed. So menopause is a relatively recent evolutionary situation, and not that we don't know anything, but there's a lot we don't know about the effects of menopause on brain functioning. So menopause is the end of reproduction. There's a big change in the hormones that are surrounding the brain. And one might think, oh, let's just give hormones back, that will solve all the problem. And some of our research has looked at that, along with other folks doing research. And just providing estrogen to postmenopausal women doesn't solve the problem. This is our research funded by the National Institute on Aging, and we have found that the reason that estrogen does not affect cognition in older postmenopausal women is because of the aging of neurotransmitter systems. So we give estrogen, but the rest of the brain continues to age, so it doesn't help the problem. It does, however, work in younger postmenopausal women. So that means there's maybe some individual differences, or it works in some people and it doesn't work in other people. And that leads us to our current study called the CHAMP, or the Cognitive Health After Menopause Study. What we're doing here is we're taking 100 postmenopausal women and we're measuring all the things we can think of, from brain imaging to cognition, psychiatric interview, menopause symptoms, reproductive history, sleep, diet, exercise, all the things. And we are then looking at the Alzheimer's biomarkers. We have PET scans, we have CSF, we have blood. We're trying to see which menopause symptoms load onto sort of good cognitive health or might load onto risk for Alzheimer's disease. We're in the middle of this study. It's a blinded study, so we don't have results to talk to you about here today, which I'm sorry about. I'd love to talk about that. And this is funded by the National Institute on Aging as well. So that's all I'm going to talk about. I want to thank my team. Research is a team sport. I have lots of people involved. I want to thank my funding from the National Institute on Aging, and thank you to the Society for Women's Health Research for having me here today.
So before I begin, let me just quickly tell you a little bit about the organization I represent. So we're a nonprofit, nonpartisan think tank, really focused on focusing on advancing and accelerating innovation in policy and practice to really improve the lives of all. I lead our Center for the Future of Aging, and so we really are very focused on this healthy longevity, this intersection of financial security, really seeing them as two sides of the same coin. Our signature program is the Alliance to Improve Dementia Care. We're in our 5th year. Actually started at the Milken Institute to get this off the ground. And we have a number of sponsors for the work that we do. A big focus area is on early detection. And there's information at your tables. I thought I'd start by, since we're talking about early, what are the barriers to early detection? So starting with physician reluctance, the Alzheimer's Association did a study in 2020. It really showed that physicians aren't really getting that training in medical school to feel confident in terms of speaking about brain health, doing early detection. There's structural barriers. There's something like a 7-minute visit with your PCP. And there's so many other things that they're working on, chronic diseases, comorbidities. They can't get to that brain health piece. Secondly, CMS isn't really recommending a tool that is consistently used for the early detection, for that cognitive assessment. And then there's the U.S. Preventative Services Task Force, which does not recommend a cognitive assessment. There's I for insufficient evidence, although that's being looked at once again. There's a complex diagnostic process. Julie talked about the PET scan, the cerebral spinal fluid. We're really excited about the blood-based biomarkers, but it's a really long process. If you do test positive for cognitive impairment, it doesn't necessarily mean you have dementia, and so there's a lot that goes into evaluating for other addressable causes like sleep apnea or hearing loss or a vitamin B12 deficiency. Again, this could take months before a definitive diagnosis. There is a shortage of dementia specialists, which is why the early detection is being moved into primary care. It's probably about a month-long wait and much longer in rural areas. And then stigma, both among consumers, it is the most feared diagnosis, and with providers. I talked about the physician reluctance. Malaz Bustani at ATNU talks about the 3 Ds. You know, D for driving, you lose your driving. The fear of losing your home and becoming dependent. And then also, the loss of dignity. And I would add a 4th, which is, potentially dismissal from your employer as more older adults are staying in the workforce. On the physician reluctance, I was on a bike trip with a neurologist who, I was really excited to see. He's like 70-something, and I'm like, I can talk to him about all the work I'm doing. And when I mentioned, he's like, I don't deal with it. I just deal with stroke patients. I can't. So that is just part of that mentality, like of nothing we can do, although there is. And there's obviously a lot of benefits to early detection. The modifiable risk factors, as Julie already covered. The clinical trials, we have already challenge with getting people from different various ethnic and racial diversity into clinical trials, which could really help. And so getting people diagnosed early or early detected and getting them into clinical trials is a huge benefit. Advanced care planning, really allowing that person living with dementia to participate in the legal and the financial, the care treatment and options that may be available, and then the drug therapies. There are the drugs that really do just treat the symptoms, but now we have two disease-modifying therapies, Leqembi and Kisunla, that just in the last couple of years, not cures, but certainly can slow down the progression. So the earlier we are diagnosing, because it's only available for mild cognitive impairment due to Alzheimer's or early stage due to Alzheimer's. So we released a report in December on improving early detection of cognitive impairment and dementia. Two primary themes. And the way we work, we do desktop research, we do a series of key opinion leader interviews, we have a working group, and then we come up with consensus-based recommendations. So that's what this represents. So the two major themes, enhancing primary care capacity because of the dementia care specialist shortage and cognitive assessment workflows, and then expanding detection beyond primary care. I'll go into the recommendations in a little bit of detail. So the first one, really normalizing those brain health discussions. So, not talk about it's a cognitive assessment, which you need to do with CPT code, but then expanding education and tailoring training to primary care providers. Additionally, really integrating the cognitive assessment into the clinical workflows into a health system. This sounds simple, but it takes leadership at the very top to really push this forward because of all the barriers that I covered. And then reimbursement, really establishing appropriate reimbursement codes. So for example, it is part of the Medicare annual wellness visit, but it's not frequently done. It's more of a observed, a lot of it is just by observation. And so if you actually want to do a brief cognitive assessment, the MOGA, the clock drawing test, the MMSC, the GPOP, there's no code for reimbursement. So that's a big barrier and inhibitor. So that was one of the key recommendations that came out of our work. The second theme is around really going to specialists, ancillary specialists, and to community settings. So expanding the training and support to specialty physicians and to allied health professionals, meaning, so there's a test going on in Toronto, Retispec, that really looks at the retina and you can see early signs of that amyloid deposits. So that's one example. And then expanding and supporting early detection in community settings. I'll go into a little bit more detail on that fourth recommendation on the report. So cardiology, hypertension is one of the most modifiable risk factors. We really talked about that. And there's growing evidence between the linkage between cardiovascular disease and Alzheimer's disease. Anesthesia. I mean, there's post-operative delirium that could really inhibit recovery. And trying to think about the pre or post-op cognitive assessment could be an opportunity. I think the biggest opportunity is with OBGYNs. I can't think of another physician where there's a longitudinal relationship with that patient. From seeing just regular pap smears and then through pregnancy and through menopause. And really just discussing brain health as part of a normal conversation throughout that. And we know that menopause, as Julie said, is, there's a precipitous decline in estrogen, which is a protective factor, especially for women. So being able to talk about this within the OBGYN practice. And then lastly, expanding and supporting early detection in community settings, faith-based organizations. There's a fabulous program called Alter Dementia, led by a nurse practitioner, PhD, Theron Epps. She had over 500 people at her Alter Dementia Summit, really going to these communities where we know there's disproportionate risk, not only for women, but also for people of color. Senior centers, community health workers, and health fairs through employers or just in the community. I will say one of the things that the Alzheimer's Association really emphasizes is that even when you're doing the community-based screenings, it's really important to have it supervised or conducted by a healthcare professional. And also you want to make sure that even if you're doing these community screenings, that there's a pathway for referral into primary care in case there is a you don't want a person to get a positive and then be left hanging for months trying to get an appointment. That's what I have. Okay, thank you.
Hi, everybody. I'm certainly delighted to be here today. As a clinician and clinical trial investigator, I am compelled to start this presentation by acknowledging and thanking the numerous people who have volunteered to participate in research, making the life-altering research advances I'm about to talk about possible. I want to thank the nearly 12 million Americans who provide unpaid care for a family member or friend with dementia at an estimated value of $413.5 billion in 2024. The dedication and perseverance of these study partners and caregivers to maintaining or improving the quality of life of a loved one, family member, or friend with Alzheimer's disease has been my greatest source of inspiration throughout my entire career. I have very exciting news to share with you, and everything I'm about to say is of particular importance to women who represent nearly 2/3 of Americans living with Alzheimer's disease today. If you are a woman, your odds of developing dementia or becoming a dementia caregiver are high. I will tell you how a groundbreaking study called ADNI has led to research advances that have fundamentally changed how we diagnose and treat Alzheimer's disease. So what is ADNI? ADNI stands for the Alzheimer's Disease Neuroimaging Initiative. It is an observational study involving over 60 clinical trial sites in the US and Canada. ADNI involves 3 primary cohorts: people with normal cognition, no changes in their memory or thinking; people with mild cognitive impairment, which is people who have memory and thinking changes beyond what's expected for their age and education, but still have preservation of function; and people with mild Alzheimer's disease. Now, ADNI has 2 main goals to improve. The first is to improve AD diagnostics. This is necessary for early detection and ultimately to accelerate the development of new treatments. And number 2, not necessarily in this order, is to provide data to researchers worldwide. ADNI is the most widely used repository of AD observational data in the world. As of today, over 6,500 scientific publications have used ADNI data, and this information has been shared with over 45,000 investigators worldwide. This data sharing has led to major breakthroughs in diagnosing and treating Alzheimer's disease. So, how has this happened? We've been looking for ways to slow down Alzheimer's disease for decades. But we came up short for years because it was so difficult. You can't see the brain, you can't tell what the drugs were doing, and you couldn't confirm if they were helping. So we had one trial after another fail. For this reason, ADNI started in 2004, so 21 years ago, as a public-private partnership led by Mike Weiner of the University of California, San Francisco, and started by the NIH, but with many private pharmaceutical and biomedical companies co-funding and partnering in the design and content of ADNI so that we could all work together to actually make progress. And it's been hugely successful. ADNI has allowed us to develop and utilize biomarkers that show us what exactly is happening in the brain in Alzheimer's disease and what medications do to those changes. So instead of trying things blindly, we can actually see what we're doing. And what's the result of this? We're now able to map out the disease and track its major abnormalities, which are amyloid plaques and tau tangles. We can see the plaques and tangles and the ordering of events leading to the toxicity and neuronal cell death in Alzheimer's disease. We know that amyloid drives the disease and tau tangles accumulate and contribute to the loss of brain function. This has directly led to the development of effective disease-slowing medications. Now we have new therapeutics, such as anti-amyloid antibodies that bind to the amyloid that's driving the process and enable clearance, allowing us to actually remove the amyloid. We can observe the effects of the treatment, test different doses, and determine the dose that's effective in removing the amyloid that drives the disease. So this came out of ADNI, but PET scans are difficult and expensive, and not widely available in vast parts of the country. So now, also coming out of ADNI, we have blood tests, and these blood tests are as accurate a picture as a PET scan in showing plaques and tangles. Now, it's not actually a picture, it's a number, but it's as precise as a PET scan in showing plaques and tangles in the brain. Now, when people are worried about their memory, we find out if they have Alzheimer's disease by doing a PET scan, or much easier and less expensive, doing a blood test that gives us the answer. If there's elevated amyloid and they're eligible for treatment, we can remove the amyloid. We can remove amyloid using new therapeutics, which are anti-amyloid antibodies that lead to a 30% slowing of the disease. So, this is a disease that develops over decades. The period which these drugs have been proven effective is the period we call early Alzheimer's disease, which means people who have mild cognitive impairment or mild dementia who initiate treatment that removes amyloid, they will have a 30% slower rate of decline than people who are not receiving these medications. We can confirm this through memory testing and functional testing, and we can verify that amyloid is being removed by using PET scans and blood tests. That means someone eligible to take these treatments for a period of years will delay every marker of decline by 1/3. And what do I mean by decline? I mean needing to go into long-term care. With 3 years of treatment and a 30% slowing of the disease, the onset of the delayed time it would be delayed to long-term care by 1 year. And since these antibodies alter the course of the disease, their benefits will persist indefinitely. If you treat for 6 years, you delay everything by 2 years. Everything downstream, everything later. Loss of the ability to drive, loss of the ability to manage your finances, loss of the ability to take care of yourself, and loss of the ability to communicate with your family. Each of those markers of decline is pushed out by 30% of the time you were on the drug. So we're talking about a minimum of months that were saved, a hugely important savings. It means that it may mean not having to go into a nursing home, or if you are treated for an even longer period of time during which the drugs are proven effective, you could be talking up to about a 2-year delay for those markers of functional loss. That's not a small effect, it's a huge effect. So now we have therapeutics used in the clinic to slow down Alzheimer's disease. And guess what? Things are going to keep getting better as we're building on this. For example, by testing combination therapies and working towards an earlier, even earlier intervention. 30% will grow to 60 or 80% and so on. That is as long as we keep working on it. Studies are being launched that combine the removal of amyloid with the targeting of tau tangles. Studies are being conducted to test anti-amyloid therapies and determine if removing amyloid, which by the way builds up 10 to 20 years before the onset of symptoms, if you remove it even earlier, before the onset of symptoms, can we be effective in preventing the onset of Alzheimer's disease? So prevention trials are underway. Screening for enrollment in prevention trials now starts with the blood test in people without memory loss or symptoms of cognitive decline. So while the focus of this hearing is on women and Alzheimer's disease, everything has changed for all of those at risk for Alzheimer's disease as a result of Alzheimer's disease clinical trial research and studies such as ADNI, which have led to clinically approved and now widely used new Alzheimer's disease therapeutics. This research must go on so that one day we can not only significantly slow the rate of decline in Alzheimer's disease, but in the future, we can wipe it out altogether through disease prevention. Thank you.
I'm going to sit down and talk, otherwise I do like the mom sway when I'm standing. I think not news to so many of you here that we are in a very partisan landscape right now. We're even seeing that it played out in real time with the reconciliation bills that are being marked up today in the House. It's a really tough time in Congress. But one thing that we at the association have always believed is that Alzheimer's is not a red or blue issue, it is a purple issue. And it's something that we've really, really seen throughout our work over the years, is that no matter what party you're part of, everybody is impacted or touched by Alzheimer's in some way. And so we have key congressional champions across the entire spectrum. I mean, there are some people that work so closely together on Alzheimer's issues that people would be shocked to see them even, having a conversation. And so that, I think, is one of the fundamental drivers of the Alzheimer's and dementia policy landscape, is being able to work in that bipartisan manner. Now, one thing that has also been a driver for us over the years has been the goal of early detection and timely diagnosis. So we just recently released our 2025 Alzheimer's disease facts and figures. You can find them online at alz.org/facts. But in that, we had a special report that was titled American Perspectives on Early Detection in Alzheimer's Disease in the Era of Treatment. And in this special report, we found that 4 in 5 Americans consider early diagnosis very important. 4 in 5 Americans would want to know if they had Alzheimer's before symptoms appear or affect daily activities. And 9 in 10 Americans would want a simple test to allow for early treatment. So it's very clear that the idea of knowing early is top of mind for Americans when they're thinking about Alzheimer's and dementia. And as the science continues to progress, we heard from some really great science pieces today, but as the science continues to progress, as we look at blood biomarkers getting more in specialty practices, eventually primary care practices, we're going to get closer and closer to that reality. So I want to talk a little bit about some of the legislation that we've seen successfully over the years and some of the stuff that we're still working on. But first I want to say that none of this would be possible without our incredible advocates who dedicate their time. They are coming up here in June for our advocacy forum. You'll see the halls of Congress turning purple on June 10th. And they really just spend so much time building these relationships with members of Congress. And none of this would be possible without them. We've also had, as I said, incredible bipartisan congressional champions who hopefully you'll see tomorrow in some hearings in front of with the HHS secretary, who will be talking about the importance of continued investment in not just research funding, but also the important programs we have like GOLD that I'll talk about in a little bit. So throughout the years, we've had legislation that's aimed to assist people living with dementia, with their families, with healthcare providers and payers to be ready for earlier diagnosis and actions. We have seen legislation that creates and then bolsters the use of care planning for cognitive impairment codes. We've created a dementia care model, management model for primary care practices to provide better, more comprehensive care. And we've driven the country toward investment in Alzheimer's and dementia research, care, and services. last year, quite a doozy of a fall in a year, we saw 3 bills unanimously clear Congress and get signed into law, which is pretty incredible, and really a testimony to our advocates in the entire Alzheimer's community. The first was the NAPA Reauthorization Act. NAPA is the National Alzheimer's Project Act, first enacted in 2011, set up an advisory council on Alzheimer's disease that is led by HHS with people sitting on the council who are from all aspects of the government who may touch Alzheimer's disease. And then it includes external stakeholders as well. And what the council does is it creates a national plan to address Alzheimer's disease, and it updates it every year. So we saw the first national plan in 2012, and now NAPA has been reauthorized through 2035. The advisory council, as I said, releases this national plan. Some of the things that we've seen in the national plan have really driven the legislative work we've done. We've seen action items to expand access to new technology to diagnose Alzheimer's disease. That's something that the FDA is focused on. We've seen work from the CDC focusing on BOLD and early detection tools for states to better implement. Another bill that we've seen that we saw signed into law was the Alzheimer's Accountability and Investment Act. We used to call it AAA, the Alzheimer's Accountability Act. That was the original one, enacted in 2014. And that allowed the scientists at NIH to directly speak to Congress with what they need. They create a professional judgment budget and send it directly to Congress to say, hey, here's the investment we need in order to meet these goals that you all have set through the national plan. It allowed funds to go from $400 million to over $3.8 billion. And again, another bipartisan, unanimous bill. The last one I want to highlight from last year is called the BOLD Reauthorization Act. And this one reauthorized an incredible program called the Building Our Largest Dementia Infrastructure for Alzheimer's Act. It's a mouthful. But this one, it was originally enacted in 2018, and it created this Alzheimer's public health infrastructure across the country. Looking to implement Alzheimer's interventions focused on public health issues like increasing early detection and diagnosis, reducing risk, and preventing avoidable hospitalizations. Since its enactment, CDC made 66 awards to over 40 state, local, and tribal public health departments. It was reauthorized for another 5 years. One of the issues that we're currently working on is in the reshuffling of HHS. We did see the Healthy Aging branch no longer exist, and that is the branch that housed BOLD. So we are continuing to work with our bipartisan champions to ensure that BOLD continues and continues the important work that it's doing. Some of the other priorities that we're really focused on this year, and you'll hear our advocates talking about, is FY26 appropriations. I think everyone in this room is probably looking at that and concerned at that. So we're continuing to ask for an additional $113.485 million, another one that just rolls off the tongue. And that's for Alzheimer's and dementia research at the NIH. And that is in line with the professional judgment budget that I talked about before. We're also going to continue to ask for BOLD appropriations of $35 million. And then we're focusing on something that touches caregivers a little bit more, and that's the Credit for Caring Act. And this is a bipartisan bill that would create a new non-refundable tax credit of up to $5,000 per year for eligible family caregivers to help address some of the financial impact that caregivers see. We are working in conjunction with AARP on this bill, and while it was not in the initial bill that was put out by Ways and Means yesterday, we are hoping that through the reconciliation process we will see it included because it's a very important tax credit. And lastly, I'm just going to go very quickly. We have a couple of other bills that are floating around in Congress or will soon be reintroduced in Congress, one of which is the Change Act. You've heard Diane mention it, but it is a bill that encourages early assessment through better utilization of the Medicare annual wellness visit. I believe it is being introduced this week or next week. So we should see that. And then there's also ADAPT, which is the Accelerated Access to Dementia and Alzheimer's Provider Training Act. We introduced this last Congress, and it really focuses on one of the issues that we heard, I think, from all three of the previous speakers, which is how can we better prepare primary care providers? How can we better train them in early detection and diagnosis, but also what do you do once you get that diagnosis? What's the next step? Treatment's not for everybody. It's a great option. It's a great thing to talk to patients about, but it's not for everybody. And so what else is there? What else can you do? And so ADAPT would look at this, it would provide grants for like video conference trainings that could be used in rural environments, in independent, smaller practices that don't have time or the ability to go to some of the bigger conferences to really learn and sort of go back to med school a little bit and take a look at Alzheimer's from the beginning through the end and how we get to each of the steps. That bill authorizes $1 million per year for 5 years, so we are working with our champions to get that reintroduced as well. So as I said, we have our big advocacy event in June. You'll see lots of people flooding the Hill in purple, discussing our legislative priorities. So stay tuned for more exciting news. Thanks, Katie.
I am gonna actually open it up to the audience first. I have questions I can ask, but I think I'd love to see if folks have questions. That way we can make the best use of our time here. So any questions to start?
Yes, so first of all, thank you. This was really enlightening and a lot of great information. And it's exciting to hear that it sounds like we're moving towards a place where we can, maybe catch this disease even before symptoms. So I guess my next question, I think Jen, you really touched on this, but from a policymaker perspective, what can they do and we do to ensure sort of like the early diagnosis, because that seems like such an important piece of this. What can policymakers do right now to encourage them?
I think one of the things that we have seen, and I will say that you may see more of this soon, but a lot of the conversations are around what is Medicare able to do right now. And I heard some of my co-panelists talking a little bit about USPSTF, the U.S. Preventive Services Task Force, and what that process looks like, what those recommendations look like. And so I think there's a couple of pathways to create coverage access for these eventual, hopefully, blood biomarkers that can maybe streamline some of the diagnostic processes. I think the science isn't quite there yet, but I think just education of lawmakers that this is where we're hoping to go, this is where we're hoping science goes, this is where science is now, and continuing to have those conversations is always beneficial at this time.
I think one of the things too, one of you mentioned this, was related to Medicare access to benefits that currently exist, right, that maybe aren't being utilized. But in addition to the education of policymakers, through those conversations with your constituents, it's really important to make sure that they know what is available to them as well. So one of the things that we're doing in partnership with Healthy Women is a women's guide to Medicare. We're starting with bone health and cardiovascular, but I see a great need in this area as well, as we're thinking about making sure that folks understand what they might have access to. And that also will help us, quite frankly, make the case for better benefits in the future as the science catches up. Yes?
I'm curious if you can talk to the commercial payer as early detection and diagnosis. We hear that 10, 20, 30 years prior, we need to start getting at a younger population, menopausal women in their 50s. What does that look like? Because that's not a Medicare population, and there's a challenge in coverage. There's a challenge at 65 plus. Can you talk about some of the opportunities in Medicare space and policy options for coverage there?
I can start. I think that a lot of private payers follow Medicare's lead. And so I think a lot of the work is getting Medicare to understand the importance of early detection and diagnosis, and ensuring coverage there. I think another piece is those ongoing conversations. We host a payer summit every year, in which we bring payers together to talk about sort of the newest things going on in the Alzheimer's space, and ways that they can better help and protect their beneficiaries. And so, we have a whole health systems department that is devoted to not only talking to health systems, but also talking to the payers and ensuring that if they're not covering one of the treatments, that we're understanding why and what else they need to figure out how to encourage the coverage. And then also, we'll be doing the same as we see these biomarkers becoming more and more available. But I think even when CMS, I guess it was 2 years ago now, updated the PET scan rule, knocking it down from what it was, private payers followed suit. And so I think, we really need Medicare to lead in this space, even if we really are looking at that pre-Medicare population.
I mentioned the need for a separate standalone CPD code for that brief cognitive assessment. This came out of the work led by our colleague Kelly O'Brien, and it's, as Jen mentioned, if CMS does it, if it's covered in Medicare, it does tend to influence what private payers do. I would love to see a day when, a woman going into their annual OBGYN practice, that in addition to getting, peeing in a cup, getting their blood pressure taken, they're doing a brief cognitive assessment. And then you're just normalizing those brain health conversations throughout the life course of that woman's life. But we're far from that.
Brigid, did you want to jump in?
Yeah, I wanted to add, as Diane was talking about, that we have a lot more work to do in reducing the barriers to early access to care. So underdiagnosis and treatment in Alzheimer's disease has been around for a long time, and we have a lot of work to go before earlier intervention in all people can actually take place. And the other thing that I think Diane, you also talked about, is there aren't enough dementia care specialty providers to manage all of the people that are going to benefit from new diagnostics and new treatments. So we have to continue working on empowering and providing the tools for primary care physicians to be able to assist their patients towards an early diagnosis.
Dr. Dumas, I think that brings up this issue of menopause, which I was explaining to someone the other day who asked me a question about menopause, and I said, we're really finding out a lot more about your brain during that time, which is concerning for a number of reasons, just in terms of thinking about, I know if anyone is going through or has been through the menopause transition, you think you're losing your mind. So, often there is confusion just around, like, what does that mean? And I'm wondering if you can talk a little bit more about sort of how you think, your research might help us guide when and how hormone therapy might be used, but also, like, what would you tell women going through this transition?
What I tell my friends is, it's terrible. So yeah, it's menopause, the end of reproduction, but all of the symptoms are neurological. So all of the things, the hot flashes, it's all controlled by your brain. And so just sort of acknowledging that, I think. So it's, we are in the middle of trying to figure out which symptoms combine together to show you that estrogen would be good for you, and which symptoms combine to show that it wouldn't be or be harmful. So, I think we're just working hard to do the research. It's a challenging thing because you have menopause around age 50, Alzheimer's diagnosis at 65, and the federal grants are 5 years. So it's really hard to get these to this long trajectory is the really difficult thing. So I think someone said we need the science to keep going with the biomarkers and sort of developing these things. So yeah, I think that there's, I don't know if it's because of TikTok or something, but there's a little bit more acknowledgement of menopause stuff. You see the sort of jokes, and it's not, I like it for the part that we're talking about it more, and not necessarily that it's the right thing to talk about. But there's some, there's some acknowledgement, some awareness of this being an important time, or a time that we should at least be talking about and making jokes about. But So yeah, I think.
Yeah, there is, for those of you who don't know, something called a menopause, which is our social media influencers, clinicians, and now celebrities as well, who talk a lot about this transition. So it would be awesome if, in addition to walking with our weighted vests, which we all should be doing anyway, that we maybe have a conversation about what does this mean for your cognitive health, and what should you be looking out for earlier.
Yes.
Other questions in the room? I have more. Yes.
I'm an emergency med doc and I'm doing a policy fellowship. And what you mentioned about the MOPA score made me think, man, like 25% of our elected officials wouldn't pass a MOPA. So what do we do with this early detection? I see this as a metabolic syndrome sort of downstream effect. As a clinician, I see that. If we find it early, then what? How does that help a person to get that diagnosis? It seems to me like it would be devastating. I wouldn't want that diagnosis.
So I think that's a good question that we talk about a lot, right? Like, what is it that you would want to know? I think, Diane, you talked a little bit about this, but it was really interesting to hear that, 4 out of 5 people said that they would want to know. Oh, sorry, was that?
Yeah, that was new info, because some of the data I'd seen before is that it is the most feared diagnosis. The more public education that we can provide to say, just because you might be experiencing, there are addressable causes. We don't have that number to know, but people who actually go in and test positive, they go in and they find out, oh, it's sleep apnea, or they have a vitamin B12 deficiency, and then, or hearing loss. Dr. Charlotte Yeh from ARP, she was the chief medical officer. She talks so much about her dad, who they thought, he was having signs of dementia. She got him hearing aids. Boom. Think about hearing loss. It just closes your world. You're not having the synapses firing in your brain. You're starting to not go out and socialize. It's a very gradual thing. You're not even aware it's happening. But I think that the more public education needs to be done about it, there are addressable causes that are the modifiable risk factors. There are disease-modifying therapies if it's caught early enough. There's a positive message here. So
I think there's also planning that can go in. Sorry. Usually I get told I'm too loud, so I thought I would just project. I think there's planning that people can do. They can do advanced care planning. They can talk through some of those tough decisions that they'll have to make later in life about, both of my grandmothers had Alzheimer's. One of them said, if you put me in a nursing home, I will haunt you from the grave. And the other one said, if you don't put me in a nursing home, I will haunt you from a grave. And so it's having those conversations, and I think, in the psychology of it all, being able to still have the control over those types of decision making, the financial decision making, having those conversations with your family of like, hey, when I get to a point where I can't drive anymore, here's how I want you to deal with it. And that gives the family more comfort, and it usually will give the person more comfort.
If you are able to know earlier, you're able to address some of it. You're able to maybe delay it, maybe plan, that sort of thing. But it really is more of like a personal choice, right? But you want to make sure people do have that choice to know. So I'm going to do a rapid fire, and then we're going to wrap it up. If you could do one thing, if you could wave a magic wand, and what is like the one thing you would want this audience to hear, and you can just go down the line.
Let's see, menopause is something that affects the brain, and it's important for our lifetime, our future healthy and pathological aging.
Building off of that, just the importance of brain health, I think. Educating members of Congress, educating your constituencies, educating everyone about brain health. And I would be remiss if I don't mention that we have a big study called US Pointer that looks at lifestyle changes, modifiable risk factors, that is reading out this summer. And we're hoping that we will see some really, really interesting data that can help form some decisions and choices.
I would just say that brain health is women's health, and we need to really have women take control and really understand what the modifiable risk factors are, and begin those conversations early on with their practitioners.
I have to wave the wand twice. I would hope for a preventative treatment to prevent future generations from developing Alzheimer's disease. And until that happens, I would wave the wand that there would be adequate support for all of the caregivers out there that are doing such important work.
Thank you all so much for that. Thank you for joining us. I think for me, and sort of, if I could pull this all together, right, understanding risk factors, modifiable importantly, knowing your risk earlier rather than later. So if you at least understand what you might be at risk for, I think that's very helpful in getting that earlier detection and that screening and diagnosis. And of course, access to care and coverage across the board is really critical as we're thinking about this. And then I have to, of course, plug sex differences research because that's what we do, right? If we can fully understand the differences between men and women and do effective, efficient research from the beginning, I think we'll all be better off, and we're seeing this in this space in particular. So thank you again. I really hope that this really will spark some ideas and partnerships. I think there's a lot going on in this space that folks can take away. And so with that, I will say, be sure to follow us on social media, visit our website at swhr.org and all of our panelists' websites and materials as well. You can see them around the room. We have a lot of free resources and tools on Alzheimer's disease and other diseases and conditions that are part of our Healthy Aging Network, but also disproportionately differently and uniquely impact women, all free and available to use, so please use them. Have a great day, everybody. Thank you.